This lecture was designed to deliver theoretical knowledge to preclinical students, so I apologize in advance that it will be mostly didactic. But I hope we'll have fun solving the clinical cases together. There will be a few recap quizzes throughout this lecture where I'll ask you guys some questions to help consolidate the knowledge. Now, without further ado, let's get into it. So, I first want to talk a bit about bones. So, as you are aware, bone consists of cells and extracellular matrix. There are three main types of cells in the bone. Firstly, we have osteoblasts, who are responsible for bone formation by synthesizing osteoid and mediating its mineralization. Osteoblasts are found lined up along bone surfaces. They arise from a mesenchymal stem cell called osteoprogenitor cell. Osteocytes are largely inactive osteoblasts trapped within formed bone. They may assist in the nutrition of bone. Lastly, osteoclasts are multinucleated phagocytic cells that break down bone. They arise from hematopoietic stem cells and are monocyte macrophage-derived cell type. The extracellular matrix exists initially as osteoid, which is an organic and mineralized bone matrix consisting of type 1 collagen, proteoglycans, osteocalcin, and osteonectin. Osteonectin binds the collagen and proteoglycans together. Osteoid then becomes mineralized by the deposition of calcium hydroxyapatite, which are calcium phosphate crystals that give the bone strength. If osteoblasts synthesize osteoid rapidly, as in fetal bone development, woven bone is produced. Woven bone is an immature form of bone with randomly arranged collagen fibers in the osteoid. Production of woven bone can also occur in adults when there's a pathological rapid new bone formation, for example, at the site of a healing fracture. Woven bones is eventually remodeled to form lamellar bone, which is physically stronger and more resilient. Lamellar bone is composed of regular parallel strands of collagen arranged in sheets. Virtually all bone in a healthy adult is lamellar bone. On the left is a picture of a long bone, which can be divided into two parts. The expanded ends are called the epiphysis, and the shaft is called the diaphysis. On the right, we've taken a cross-section through the long bone, which generally has two layers. The outer layer consists of compact bone, also called cortical bone. It forms the dense walls of the diaphysis, and it also prevents strength to the bone. The inner layer consists of spongy bone, also called cancellous bone or trabecular bone. Spongy bone occupies part of the large central medullary cavity. Spongy bone consists of a network of fine, irregular plates called trabeculae, separated by intercommunicating spaces, which is occupied by bone marrow. Spongy bone is less sturdy. The articular surfaces of the epiphysis are protected by a layer of specialized hyaline cartilage called articular cartilage. The external surface of bone is invested by a dense fibrous layer called the periosteum, into which are inserted muscles, tendons, and ligaments. The inner surface of bone, including the trabeculae of spongy bone, are invested by a delicate layer called the endosteum. The endosteum and the periosteum contains cells of the osteogenic series, which are responsible for growth, continuous remodeling, and repair of bone fractures. So fetal development of bone occurs in one of two ways. The first is endochondral ossification, shown in blue, which is bone formation through a cartilage intermediate. The next type is intramembranous ossification, shown in purple, which is bone formation through direct mesenchymal progenitor cell. So if you look at the image on your right, it shows that long bones, vertebra, pelvis, and bones of the base of the skull developed by the process of endochondral ossification. The formation of the bones is preceded by the formation of a continuously growing cartilage model, which is then progressively replaced by bone. The bones so formed are called cartilage bones. On the other hand, bones of the vault of the skull, the maxilla, most of the mandible, and the clavicles develop by intramembranous ossification. The formation of the bones occur by the deposition of bone within primitive mesenchymal tissue. The bones so formed are called membrane bones. So now we're going into bone remodeling. As we all know, linear bone growth ceases in adults, but bones are dynamic tissues that undergo continual remodeling throughout life in response to mechanical stress. Mechanical stress causes microfractures in bone, which is sensed by osteocytes. Bone remodeling occurs also to regulate calcium in the extracellular fluid. There are 5 phases to bone remodeling. Phase 1 is called activation, which is shown in the image on the right. So we have the pre-osteoclasts, and they are stimulated and undergo differentiation into mature multinucleated osteoclasts. The activation step is also called osteoclastogenesis. Upstream pro-resorptive cytokines, for example, PTH, interleukins, TNF-alpha, and glucocorticoids, stimulate pre-osteoblast, also called stromal cell, shown in yellow, to express RANKL on the plasma membrane to secrete soluble RANKL, as well as OPG and MCSF. OPG here is a decoy receptor for RANKL, so it binds to soluble RANKL and RANKL on pre-osteoblast and prevent them from binding to RANK on the osteoclast precursor, thus regulating osteoclastogenesis. MCSF binds to CFMS on osteoclast precursor, and soluble RANKL bind to RANK on osteoclast precursor. Osteoclast precursors then fuse and differentiate into mature osteoclasts. Now we enter phase 2, resorption, which is shown on the left. Osteoclasts attach to bone surface, much like a section cap, forming a ruffled border. Inside the cytoplasm of the osteoclast, we have CO2 and H2O being turned into H+ and bicarbonate by the enzyme carbonic anhydrase. The H+ ion is secreted out through the apical H+ ATPase. The bicarbonate is transported out through the basolateral chloride bicarbonate exchanger in exchange for chloride, which is then excreted out through the apical chloride channel. Overall, osteoclasts secrete HCl. It also secretes proteases, and the combination of acids and enzymes dissolve the bone matrix. Phase 3 is called reversal, which is the end of resorption, where an osteogenic environment is generated. Phase 4 is formation. Within the bone matrix, we have sequestered growth factors like TGF-beta, IGF-1. When acid and enzymes degrade the bone matrix, they actually liberate these sequestered growth factors, which work to recruit osteoblasts to the cell surface. In response to these growth factors, osteoblasts would start to synthesize new osteoid. Phase 5 is quiescence, where osteoblasts terminally differentiate into bone lining cells or are integrated into the new osteoids to become osteocytes. So I hope that all makes sense, and this has relevance to the pharmacological management we have for some bone diseases, which we'll touch on later. Now, moving on to calcium homeostasis, this is closely linked to bone health. So firstly, calcium in the body is distributed in the following way, and you can look at the diagram on the right. So 99% of calcium in the body is in the bones, and most of these exist in the form of calcium hydroxyapatite crystals. Bone calcium forms a reservoir which can be tapped to maintain plasma calcium homeostasis. Usually, only a small fraction of bone calcium is ionized and readily exchangeable. And this pool remains in equilibrium with the calcium in the interstitial fluid. 0.9% of the calcium in the body is in cells, as you can see here. The concentration of free calcium in the cytosol is 0.001 millimolar. You don't need to remember the numbers, they're just there to give you some ideas. In addition, calcium is concentrated inside mitochondria and cytoplasmic reticulum. Electrochemical gradients favor movement of calcium into the cytosol when calcium channels open. Lastly, 0.1% of the calcium in the body is in the extracellular fluid. In the plasma, 50% of the calcium is bound to plasma proteins and other molecules. The unbound calcium is free to diffuse across membranes through open calcium channels. The total plasma calcium concentration is 2.5 millimolar. Calcium has 4 functions in the body. It is a signal molecule. So calcium enters the cytoplasm to initiate exocytosis of synaptic and secretory vesicles, contraction of muscle fibers, or altered activity of enzymes and transporters. It is also a part of the intracellular cement that holds cells together at tight junctions. It is a cofactor in the coagulation cascade. And plasma calcium concentrations affect the excitability of neurons. So what happens when calcium levels becomes too high or too low in the body? Does anyone know what happens and what signs we can look out for hypocalcemia? It would be great if you can send some answers in the chat. You can send me a private message as well if you would like with the answers. Okay, that's all right. I haven't seen any answers in the chat, but oh, thank you, Alex. Poor bone health. Yes, I guess, well, it's difficult to tell whether hypocalcemia causes poor bone health or the other way around. Oh, yes, I see another answer in the chat saying muscle cramps, and that is correct. So I just wanted to touch on how calcium affects the excitability of neurons. So if plasma calcium falls too low, neuronal permeability to sodium increases. That causes neurons to depolarize and the nervous system becomes hyperexcitable. In its most extreme form, hypocalcemia can cause sustained contraction, also called tetany, of the respiratory muscles, resulting in the body being deprived of oxygen, leading to unconsciousness or even death. So in addition to tetany, hypocalcemia can also cause seizures, QT prolongation, twitching of the muscles, and spasms as well. So thank you so much for the answer in the chat. And on the other hand, hypercalcemia has the opposite effect of depressing neuromuscular activity. And there's a famous mnemonic that medical students use to remember the effects of hypercalcemia. Does anyone know what I'm referring to? It rhymes really well. And it is stones, moans, groans, psychiatric. Nice try, Megan. I always get it. I always miss 1 or 2. So it is stones, bones, groans, thrones, and psychiatric overtones. So stones stand for renal stones. Bones stands for bone pain. Groans means abdominal pain. Thrones talks about increased urinary frequency, and psychiatric overtone refers to anxiety or altered mental status. Good job. So as you can see, calcium performs critical functions in the body and must be tightly regulated. To understand how calcium is regulated, it helps to understand a little bit about the input and output of calcium in the body. As you can see on the diagram, for input, calcium is absorbed through the diet in the small intestine. Only 1/3 of ingested calcium is absorbed. The remaining 2/3 passes out in the feces. As for output, most calcium is excreted through the kidneys, but a small amount is excreted in the feces. Ionized calcium is freely filtered at the glomerulus then absorbed along the length of the nephron. Hormonally regulated reabsorption takes place only in the distal nephron. So that brings me to the 3 hormones that control calcium balance. Can someone tell me, firstly, what is PTH? Where is it released from? And does it increase or decrease plasma calcium level, please? I didn't want to say the full name of PTH because that gives the answer away. Does anyone remember what it stands for? Amazing. So someone just said in the chat, it stands for parathyroid hormone. It is therefore released from the parathyroid gland. And I'll answer the last question myself for this one. Its purpose is to increase plasma calcium level. Amazing. I also see that in the chat. So a decrease in plasma calcium is detected by calcium sensing receptors on chief cells of the parathyroid gland, and chief cells release PTH. And PTH acts in a few ways. It first acts on the bone to increase bone resorption. It does this by acting on the osteoblast to increase the expression of RANKL, and also inhibit the secretion of OPG, which leads to osteoclastogenesis and bone resorption. PTH also acts on the distal nephron to increase calcium reabsorption and decrease phosphate reabsorption. These opposing effects of PTH on calcium and phosphate are necessary to keep their combined concentrations below a critical level. If their combined concentration exceeds that level, calcium phosphate crystals form, and a high concentration of those in the urine are one cause of kidney stones. Lastly, PTH acts on the proximal convoluted tubule in the kidneys to increase 1-alpha hydroxylase activity. Does anyone know, does anyone remember what 1-alpha hydroxylase do? It is related to another hormone we're about to talk about. Okay, I'm assuming you want me to tell you the answer. So 1-alpha hydroxylase is responsible for producing active vitamin D in the body, which is the next hormone we're about to talk about. And I'm assuming you've guessed that if PTH acts to increase active vitamin D or calcitriol in the body, they must serve similar functions, and that is correct. So calcitriol is the biologically active form of vitamin D. It acts on bone to increase bone resorption, similar to PTH. It acts on distal nephron to increase calcium and phosphate reabsorption. It acts on the GI tract to increase calcium and phosphate absorption. So just to recap, there are 2 main differences between PTH and calcitriol that you should be aware of. So calcitriol acts on the GI tract, PTH does not. Instead, PTH acts on the proximal convoluted tubule to increase 1-alpha hydroxylase activity, therefore increasing calcitriol levels in the body and indirectly increase plasma calcium concentrations. Calcitriol acts on the distal nephron to increase calcium and phosphate reabsorption, but PTH acts on the distal nephron to increase calcium but decrease phosphate reabsorption. So that's all the points I wanted to make about those 2. The last hormone is calcitonin. Can someone guess what that does to the plasma calcium concentration? That's right, decrease, because the top 2 increase, we must have someone to decrease the level. So an increase in plasma calcium stimulates C cells, also called parafollicular cells in the thyroid gland, to release calcitonin. And calcitonin essentially does the opposite of everything we just talked about. So calcitonin acts on bone to inhibit bone resorption. Calcitonin acts on distal nephron to inhibit calcium reabsorption. It acts on the proximal convoluted tubule to inhibit 1-alpha hydroxylase activity. And lastly, it acts on the GI tract to inhibit calcium absorption. Perfect. So now we've reached our first recap, and I really need your help in this. Oh, and also I just saw a question in the chat, parafollicular cells and C cells the same? And that is, the answer is yes. Okay, so moving on to recap, what are the 3 main types of cells found in bone? Could someone just write them out? Amazing. Osteoblasts, osteoclasts, osteocytes. What is the difference between woven bone and lamellar bone? So which one's stronger and which one is more mature? I can re-explain this part again. So woven bone is an immature form of bone with randomly arranged collagen fibers in the osteoid, and they form during fetal bone development or during pathological new bone formation, for example, at the site of a healing fracture. And woven bones is eventually remodeled to form lamellar bone, which is physically stronger and more resilient because it is composed of regular parallel strands of collagen arranged in sheets. Perfect. And what is endochondral ossification? Which bones are formed by it? It's a long list to remember, and it's not that clinically important. But thank you so much for the answer in the chat. So it is bone formation through a cartilage intermediate, and long bones, vertebra, pelvis, and bones of the base of the skull are formed by it. And the next question is intramembranous ossification. It is bone formation through direct mesenchymal progenitor cells, and it forms the bones of the vault of the skull, the maxilla, most of the mandible, and the clavicles. Perfect, great. So now we've reached our first clinical case, which is the exciting part. So we have a 68-year-old woman presents to the GP to receive her most recent DEXA scan results. And it shows a T-score of -2.8 at the total hip, a T-score of -2.2 at the lumbar spine, and a Z-score of -0.8. Can someone try to interpret this DEXA scan for me? What would you tell the patient with these results? Perfect, thank you. Osteoporosis is the correct answer. And just to go through the basics of interpreting the DEXA scan. So DEXA scan is the gold standard method to measure bone mineral density. In adults, bone mineral density at the total hip, lumbar spine, and the femoral neck give the best indication of fracture risk. And T-score is the number of standard deviation by which a patient's bone mineral density varies from the young adult mean for their sex. In other words, T-score takes this patient's bone mineral density and compares it to the young adult mean for females. T-score of -1 or higher is normal. T-score between -1 and -2.5 is classified as osteopenia, and T-score of -2.5 or lower is classified as osteoporosis. And the relative fracture risk doubles for every standard deviation decrease in T-score. Z-score is the number of standard deviations by which a patient's bone mineral density varies from the age and sex matched mean bone mineral density. In other words, it takes this patient's bone mineral density and compares it to the mean bone mineral density for 38-year-old females. T-score is the only score that is used in the diagnosis of osteoporosis or osteopenia. And Z-score is not used for that purpose, but it gives the patient some idea about how they're doing compared to people of the same age and sex. Because this patient has a T-score of a number lower than negative 2.5, she does indeed have osteoporosis. And why did this patient even get a DEXA in the first scan? What in the first place? Well, in Australia, the RACGP guidelines say that all postmenopausal women and men aged above the year of 50 years should undergo a clinical assessment for risk factors every 12 months. If they're at increased risk for osteoporosis, they should have a DEXA scan to check their bone mineral density. Can someone give me a few risk factors for osteoporosis that you know of? There are a lot of them. Does anyone have a good mnemonic for it? Yeah, so the good mnemonic is called Shattered Family, and I recommend you to search that up, or maybe I can send it in the chat. Maybe I can send it in the chat in a bit. But I also just got some answers in the chat. So loss of sex hormones is a good one. So low testosterone or low estrogen increases your risk of osteoporosis because sex hormones are important for bone health. Megan also said poor nutrition, physical inactivity, prolonged HRT. So poor nutrition, that's correct, and especially vitamin D deficiency is a known risk factor. Physical inactivity is another one, along with prolonged immobility, to the extent that patients can't even leave their own home or do any housework. Prolonged HRT, I don't think is a risk factor because we, as I've said, estrogen, which is a part of HRT, is good for bone health. And that's something we'll touch on a bit later. Someone also said in the chat that hyperthyroidism and hypothyroidism, in my knowledge, only hyperthyroidism or excessive thyroxine, for example, as a medication, is a known risk factor. And the other one is indeed hyperparathyroidism. So those are really good answers in the chat. Thank you for that. This is the mnemonic Shattered Family that I just sent to everyone. Just to recap a few more, or if it helps you, I categorize the risk factors into two categories. The first are risk factors for primary, if you can call it that, primary osteoporosis. So those are things like intrinsic factors like past or family history of fragility fractures, smoking, high alcohol intake, vitamin D deficiency, low body weight, recurrent falls, and what people have said before, low levels of physical activity and prolonged immobility. The other category is medical conditions and medications that can cause secondary osteoporosis. So a big category is endocrine disorders, which includes hypogonadism, Cushing's syndrome, primary hyperparathyroidism, as well as hyperthyroidism. Eating disorders is one. Inflammatory conditions like rheumatoid arthritis, malabsorptive disorders like celiac disease, chronic kidney disease or chronic liver disease, multiple myeloma, as well as diabetes mellitus of either type. These are all medical conditions that can cause osteoporosis. Medications-wise, there are a few, but there's one really big one. Can someone tell me what it is? It's also in the mnemonic that I just sent. Someone said PPI, and that's a really good one to remember because people don't often think about it. So prolonged PPI use is a risk factor, but the big one I'm thinking of is corticosteroids. And the rough kind of idea is if you have corticosteroids for, if you take 7.5 milligram for greater than 3 months, that significantly increases your risk. Some other medications are anticonvulsants, excessive thyroxine, anti-androgens, for example, those we use for prostate cancer. Oh, I'm sorry. I sent the mnemonic to everyone in the waiting room. Here it is. I've sent it to everyone in the chat now. Hopefully you can see that. Perfect. So now moving on to the next slide. The diagnosis of osteoporosis can occur by one of two ways. As we all know, osteoporosis is characterized by low bone mineral density. It doesn't have any clinical manifestations until there's a fracture. And the most common fracture is a vertebral fracture, and other common ones are hip fractures and distal radius fractures. So the first way to diagnose someone with osteoporosis is for any individuals over the age of 50 who sustain a fracture following minimal trauma, for example, a fall from standing height or less, should be considered to have a presumptive diagnosis of osteoporosis. The second way to diagnose it in the absence of a fragility fracture is by measuring bone mineral density using a DEXA. And a t-score of -2.5 or lower at any site indicates the diagnosis of osteoporosis. So how do we manage osteoporosis? Can someone give me some ideas? I think it was Megan that has already given us an idea, HRT, which I will talk about. But what is the first line treatment for? Perfect. You've given us the correct answer as well. For this one, bisphosphonates is the first line. Great. So obviously that also, yes, and Megan talked about the non-pharm ones. Very, very good. So the non-pharm ones are listed on the slides, and they mainly address the risk factors we've talked about, or at least the modifiable risk factors like smoking. So you can read that in your own time. Pharmacological therapy wise, first line is bisphosphonates, which are enzyme-resistant analogs of pyrophosphate. So bisphosphonates bind to calcium and then are integrated at high concentrations in the bone matrix. They're quite resistant to enzymatic degradation by osteoclasts, and they can remain in the body for years. This is why a drug holiday of 2 to 3 years can be considered after 3 to 5 years of treatment for patients with a low fracture risk or a normal T-score on repeat DEXA. Oral forms of bisphosphonates are taken either daily or weekly. And they have terrible oral bioavailability. So they must be taken on an empty stomach with a glass of water in the morning. The patients should be told that they need to remain upright for at least 30 minutes after taking the tablet to avoid GI side effects like nausea, vomiting, diarrhea, but also esophagitis. Zoledronic acid, which is the IV form of bisphosphonate, is given as an infusion over at least 15 minutes once every year. And zoledronic acid can cause hypocalcemia, and we've talked about before how terrible that can be. So before the first dose, we need to measure the patient's UEC, CMP, and the serum 25 hydroxy vitamin D level to make sure those are all normal before we start them on therapy. Now, another important thing with bisphosphonate is that they are renally cleared. So they're not recommended if eGFR is below 40. And zoledronic acid specifically is contraindicated in stage 4 chronic kidney disease. So what can we use for patients who have poor kidneys? Well, we can use the Nusimab. The Nusimab is safe regardless of the level of renal function. And it is a human monoclonal antibody that inhibits both the membrane-bound and the soluble form of RANKL, and by doing so, it reduces osteoclastogenesis. Denosumab is given subcutaneously every 6 months. Before you start the therapy, you must explain to the patient that denosumab must either be continued indefinitely or be replaced by bisphosphonate therapy if stopped. The reason is that unlike bisphosphonate, which have a long skeletal half-life, Stopping denosumab leads to rapid increase in bone turnover and loss of bone mineral density. And an important point to remember for long-term bisphosphonate therapy and denosumab therapy is that they have both been linked to increased risk of skeletal adverse effects, such as osteonecrosis of the jaw and atypical fracture of the femur. The risk of the osteonecrosis of the jaw calls for good dental health and care in patients taking anti-resorptives. And usually you would want them to have good you would want them to have dental clearance before they're even started on the medication. And talking about other options, if the first line fails, the first one is teriparatide. Does anyone know what it is? It's a synthetic form of a hormone that we've talked about before. Perfect. Someone has written PTH analog, and that is correct. And that may be confusing for people because we've talked about PTH's function being increasing bone resorption. And the fact is, teriparatide has a paradoxical behavior. At small doses for a short period of time, it actually promotes osteoblast activity. Only at high doses for long periods of time does it promote osteoclast activity. In fact, currently, teriparatide is the only osteoporosis treatment that increases bone formation. Teriparatide's use is limited by strict eligibility criteria for PBS subsidy. It must be started by a specialist, and the patient must have a T-score of -3 or less, and at least 2 minimal trauma fractures, including a fracture that occurred after at least 1 year of anti-resorptive therapy. Therefore, our patient isn't even eligible at this point, nor is the GP even able to start the medication. The maximum recommended lifetime duration of teriparatide is 18 months due to a risk of osteosarcoma shown in mice. You can start anti-resorptive therapy after you finish the Nusimab. Teriparatide. And the second option is estrogen. So estrogen has a protective effect on bone. It decreases apoptosis of osteoblasts and increase apoptosis of osteoclasts. Estrogen replacement therapy is effective in preventing loss of bone mineral density and reducing the risk of fractures if given to women before the age of 60. That's what the research evidence show. And the most common form of this therapy is hormone replacement therapy, or HRT, which contains estrogen plus or minus progesterone. Estrogen without progesterone is appropriate only for women who have had a hysterectomy because unopposed estrogen increases the risk of endometrial cancer. Estrogen with progesterone is the usual regime prescribed for women with an intact uterus. And treatment of HRT in general, regardless of the indication, is limited to 5 years due to risks of breast cancer, stroke, and venous thromboembolism, which includes deep vein thrombosis or pulmonary embolisms. And the question in the chat just asked to confirm that teriparatide decreases bone resorption. Yes, at small doses for a short period of time, it actually promotes osteoblast activity and reduces osteoclast activity, and therefore it reduces bone resorption. And it increases, and I'm pretty sure it increases bone formation, and it is the only drug to be able to do so currently. The last option I've written on the slide is selective estrogen receptor modulator, or SERM, SERM. And there are 2 SERMs that we need to know about in medical school. Generally, SERMs are estrogen receptor antagonists in the breast and estrogen receptor agonists in the bone. And so it decreases the risk of breast cancer while protecting the bone. The first SERM that you may have heard of is tamoxifen, which is used to treat cancer. Tamoxifen is an estrogen receptor partial agonist in the endometrium, and so it increases the risk of endometrial cancer. On the other hand, raloxifene is used to treat osteoporosis, and it is estrogen receptor antagonist in the endometrium, and so it doesn't increase the risk of endometrial cancer. It is particularly useful in younger postmenopausal women at risk of vertebral fracture with a prior or family history of breast cancer. Common side effects for both tamoxifen and raloxifene is an increased risk of venous thromboembolism due to their effects on estrogen. Great. So now we have another case. We have a more chronic presentation this time. A 72-year-old man presents with knee pain that came on gradually and is slowly getting worse with time. Based on that information, what differentials are you thinking of? Yes, osteoarthritis is a good thought. What is something related to osteoarthritis that you usually think about at the same time? Rheumatoid, that is correct. Those were the two ones I was thinking of. And out of these two, which one is more likely given that the patient is presenting at relatively old age of 72? Rheumatoid or osteo? Osteoarthritis is more common in this age group. Rheumatoid arthritis usually come on around the age of 50, as it is an autoimmune disorder. Perfect. And if this was an acute presentation, if I tell you the pain started suddenly and it is quite severe, what diagnoses would you be thinking of and really want to rule out? Gout is the first one. Pseudo-gout, yes, always a differential to consider together with gout. Anything else? Yes, septic arthritis is the big one to definitely exclude. And other ones would just mainly be associated with trauma. So ligament injury or tear, a fracture, a meniscal tear of the knee joint, or even hemarthrosis, which is acute bleeding into the joint. Perfect. So now I just want to talk a bit about osteoarthritis and rheumatoid arthritis. Oh, sorry, I lost my slide, did I? Coming back, there we go. So the pathogenesis of osteoarthritis is mechanical, as someone has mentioned in the chat. Wear and tear destroys the articular cartilage, resulting in inflammation with inadequate repair mediated by chondrocytes. Modifiable risk factors for osteoarthritis are obesity and joint trauma. Non-modifiable risk factors are old age, female gender, and family history. Osteoarthritis is largely a clinical diagnosis. The typical presentation is pain, swelling, and stiffness in weight-bearing joints after use, for example, at the end of the day. The symptoms improve with rest. Morning stiffness may occur, but usually lasts less than 30 minutes. And osteoarthritis can affect any joints, but the most commonly affected joints are the joints of the hands, cervical spine, lumbar spine, hips, and knees. In the hands, osteoarthritis can involve the DIP joints. You can see on the image on the left, they manifest as Haberdens nodes, which are just osteophytes growing at the DIP joint. You have osteoarthritis can affect the PIP joints, forming Bouchard's nodes. And it can also involve the first CMC joint. But osteoarthritis usually doesn't affect the MCP joints, which are the knuckles here. In the knee, the cartilage loss usually begins medially, resulting in bow leg or genu varum. And classically, knee osteoarthritis is described as asymmetrical, but research shows that bilateral joint involvement is common with time. An important feature of osteoarthritis is that there's no systemic symptoms. There are 4 joint findings of osteoarthritis on X-ray that you need to know. And the mnemonic I use is loss. So loss of joint space, osteophytes, subchondral sclerosis, and subchondral cysts. Radiological findings of osteoarthritis are poorly correlated with symptoms. And in isolation, they do not indicate the need for management. Now moving on to rheumatoid arthritis, the pathogenesis of this is autoimmune. So inflammation induces formation of pannus, which is a proliferative granulation tissue that erodes articular cartilage and bone. Risk factors for RA include female gender, smoking, and family history, as well as HLA-DR4. Diagnosis of rheumatoid arthritis is made on the basis of clinical presentation in association with autoantibodies and evidence of systemic inflammation, for example, increased ESR and CRP. The typical presentation is pain, swelling, and morning stiffness lasting for 30 minutes, and the symptoms improve with use of the joints. The most commonly affected joints include the wrist, the MCP joints, and the PIP joints. The first CMC and all of the DIP joints are typically not affected. And that differentiates it from osteoarthritis. Deformities are demonstrated in the image on the right, which includes ulnar finger deviation, swan neck deformity, which is DIP flexion with PIP hyperextension, and Boltonius deformity, which is PIP flexion and DIP hyperextension. Joint involvement in RA is symmetrical, and you may expect systemic symptoms like fever, fatigue, and weight loss. Extra-articular manifestations are common and includes rheumatoid nodules in subcutaneous tissues. These are usually found over finger joints and elbows. You can see inflammatory eye conditions such as scleritis, Sjogren's syndrome, which has an autoimmune destruction of the lacrimal glands and salivary glands, resulting in dry eye and mouth. Other autoimmune conditions associated with IA include interstitial lung disease, pleuritis, and pericarditis. Can someone tell me what autoantibodies we look for in the blood for a diagnosis of RA? Yes, someone wrote anti-CCP and rheumatoid factor. Which one's more specific for RA? Anti-CCP is more specific. That is correct. So rheumatoid factor is present in 70% of patients with established RA. It is detected less frequently in early disease. In contrast, anti-CCP antibodies are usually present before the development of symptoms and have a higher specificity for RA. However, 30% of patients with RA never develop rheumatoid factor or anti-CCP antibodies and are said to have seronegative disease. The typical age of onset for RA is around the age of 40 to 50, which is when kind of a lot of autoimmune conditions present. There are 4 joint findings of RA on X-ray that you need to know. The mnemonic I use is LOSC, so loose. It stands for loss of joint space, osteopenia, soft tissue swelling, and erosions. Great. Now we move on to the management for osteoarthritis. And I won't quiz you guys because I want to also finish on time for everyone's sake. So management-wise, we can divide it into non-pharm, pharm, surgical. The non-pharmacological methods are listed on the slides, and among these, weight loss for overweight patients and exercise for all patients are very important methods. In terms of pharmacological treatment, we have a few options, but none of them really work to modify the disease. You can use topical NSAIDs and capsaicin for short-term pain relief. You can give oral NSAIDs and paracetamol for pain relief. Oral NSAIDs are more effective, but they also have greater potential for harm, particularly for older people who are the population most commonly affected by OA. Some side effects to consider are cardiovascular ones, including hypertension, myocardial infarction, stroke, and cardiovascular death, gastric ulcers, and renal impairment, especially when paired with diuretics and ACE inhibitors. You could also try intra-articular injections. They are used for longer-term pain relief. and they last for a variable amount of time. Duloxetine is usually used as an antidepressant. It may be considered for patients with knee osteoarthritis who have persisting functional impairment and pain. Surgical options for hip and knee osteoarthritis include osteotomy, where either the tibia or the femur is cut and then reshaped to relieve pressure on the knee. Joint replacement is usually the last resort. Great. Moving on to rheumatoid arthritis, which is a bit more complicated but also more promising. The broad principles of pharmacological management of RA is as follows. So we need to induce clinical remission of RA to prevent joint damage, and we use conventional synthetic DMARDs or CS DMARDs, and these are started as soon as possible. Methotrexate is the drug of choice for most patients. It inhibits dihydrofolate reductase in humans, resulting in decreased pyrimidine synthesis. Corticosteroids are often combined with CS DMARDs during the induction phase to achieve rapid symptom relief. If the patient doesn't respond adequately, then we try a biological DMARD or targeted synthetic DMARDs. Symptom management include non-pharmacological strategies like rest and pacing activities, thermal therapy, exercise therapy, and pharmacological strategies include oral NSAIDs. Lifestyle-wise is really the basic we recommend to all people. Smoking cessation is a big one because it is a risk factor for RA. Okay, moving on to our second recap. What are two ways of diagnosing osteoporosis? Yes, one of the answer is DEXA scan. What's the other method? Yes, history of fragility fracture in individuals greater than the age of 50 years. And second question, what do you need to tell, how would you tell a patient, what are the instructions for patients taking oral bisphosphonates? Yes, thank you for the answer in the chat. So you tell the patient to take it on an empty stomach with a glass of water in the morning. For 30 minutes after taking the tablet, you should remain upright to avoid side effects like esophagitis. You're also advised to have dental clearance from your dentist before commencing this treatment. And that is due to the risk of osteonecrosis of the jaw, which is actually the answer to the fourth question. I'm sorry, I just told you guys the answer. So it is, for question 4, it is osteonecrosis of the jaw and atypical fracture of the femur. Okay, so for question 3, jumping back, what do we need to tell the patient about the Nusimab therapy? So we tell them it's a 6-monthly subcutaneous injection. And how long would we use it for? So we tell them to use them either indefinitely or they have to be replaced by bisphosphonate therapy soon after cessation. Great. And the last question, what is the maximum recommended lifetime duration of teriparatide? $18 months due to risk of osteosarcoma proven in mice. Perfect. That will really impress specialists. There's a second part to this. I can go through some of this quickly because you would already know the answers. So the big difference in osteoarthritis and rheumatoid arthritis is that in osteoarthritis, the symptoms are worse after use and improve with rest, whereas rheumatoid arthritis is the opposite. And according to textbooks, osteoarthritis morning stiffness lasts less than 30 minutes, but the ones in RA last longer. In the hands, osteoarthritis can involve the DIP joint as Haberden nodes, the PIP joints as Bouchard nodes, and the first CMC joint, the lateral wrist. But osteoarthritis typically do not affect the MCP joints. Question 8, the most commonly affected joints in RA include the wrist, the MCP joints, and the PIP joints. The first CMC and DIP joints are typically not affected. Some classic deformities include ulnar deviation, swan neck deformity, and Boltonius deformity. What are the 4 joint findings on X-ray in rheumatoid arthritis? In osteoarthritis? Can someone type them out for me? It is quite important for exams. Thank you. I'm seeing the answer in the chat. So it's loss of joint space, usually asymmetrically. As I've said, the medial department loses their cartilage first. You have osteophytes, you have subchondral sclerosis and subchondral cysts. What are the findings for RA? Loss of joint space, osteopenia, soft tissue damage, and erosions. Perfect. Well, actually, soft tissue swelling and erosions. Lastly, rheumatoid factor and anti-CCP are measured for suspect RA patients, and anti-CCP is more specific. Wonderful. Moving on to the second part of this lecture, antimicrobial agents. I would first like to talk about the ways we use to classify them. First way is by source. So if the antimicrobial agent is naturally occurring, we call it an antibiotic. Example is penicillin G or benzopenicillin, discovered by Alexander Fleming. If the antimicrobial agent is synthetic, we call it a chemotherapeutic agent. If the antimicrobial agent is synthesized from naturally occurring substance, we call it a semi-synthetic agent. Companies make semi-synthetic agents mainly to alter the pharmacological properties of the drug, for example, to reduce its toxicity or to improve its antimicrobial spectrum. The second way to classify them is by broad mechanism of action. If you recall, bacterial growth goes through 4 phases. Lag phase, where the bacteria adapt themselves to the growth conditions. Log phase, where they multiply very rapidly. Stationary phase, where growth rate equals death rate. And death phase, where bacteria die. Bacteriostatic agent is an agent that causes bacteria to enter into a premature stationary phase. So they're no longer replicating. Bactericidal agent causes bacteria to enter into a premature death phase. You would think that bactericidal is better than bacteriostatic, but that's not necessarily the case. Because if you hit the bacteria with bacteriostatic agent and stop it from growing, the bacteria will be cleared away by the immune system anyways. So using either agents, the bacteria will die. There are 2 scenarios where the choice of bactericidal is favored over bacteriostatic drugs. The first is if the patient doesn't have an active immune system. The second is if the patient has endocarditis. Since the infection is on the heart valves, it is too difficult for phagocytes to reach. Our focus, however, will be on the pharmacological class, which is the third method of classification listed on this slide. We'll go through each class in turn. So the first class is tetracyclines, and some names you may remember is tetracycline and doxycycline. Tetracycline binds to 30S ribosomal subunits and stops bacteria translation. Tetracycline is naturally occurring. Doxycycline and minocycline are semi-synthetic. Tetracycline is taken 4 times a day. Doxycycline is only taken once a day, and it is preferred because of this. It is commonly used for intracellular pathogens and those that cannot be cultured, for example, Mycoplasma, Chlamydia, and Legionella, which is why doxycycline is an empirical antibiotic for atypical pneumonia presentations. Adverse effects of tetracycline include GI distress, discoloration of teeth, and inhibition of bone growth in children, as well as photosensitivity. They are also contraindicated in pregnancy. The second class is beta-lactam antibiotics, which is the big class. Beta-lactam antibiotics have a beta-lactam ring, which we'll talk about later. There are 4 classes of beta-lactam antibiotics shown in the green flow chart above. The first is penicillin, and penicillin G was the first beta-lactam antibiotic to be discovered. It acts on gram-positive cocci, gram-positive rods, and gram-negative cocci. Note, it doesn't act on gram-negative rods. It is incredibly safe and can be given in high doses to just about anybody, given that they're not allergic to penicillin. It can be given in pregnancy without any problems. One disadvantage is that penicillin G is acid labile. It is destroyed in the stomach in a non-predictable way. Hence, if you give penicillin G by mouth, you don't know how much is actually reaching the body. Therefore, penicillin G is given by injection, which many people do not enjoy. Penicillin V was the first semi-synthetic penicillin to be licensed. It arose out of modification of a side chain that made penicillin G more acid stable, therefore could be given by mouth, and that improved doctor-patient relationships. Ampicillin can be taken by mouth. It has a broader spectrum of activity than penicillin G because it also acts on gram-negative rods, for example, E. coli and Salmonella. Does anyone know the difference between ampicillin and amoxicillin? I'm sure you would have seen both quite commonly in clinical practice. Okay, I'm not seeing a response. So this was actually a trick question because they are exactly the same antimicrobial agent, just that amoxicillin came out as the patent for ampicillin was about to expire. So that's a fun fact for you to know about. The next penicillin is methicillin. And it's discovered after we found penicillin G resistant Staphylococcus aureus. So these penicillin G resistant Staphylococcus aureus produce beta-lactamases that destroy the penicillin, the beta-lactam ring in penicillin G. Therefore, penicillin was discovered, sorry, correction. The beta-lactamase do not destroy the ring, but they just inhibit penicillin G from working, which I'll explain later. So methicillin was developed to treat penicillin G resistant Staphylococcus aureus. They're not used anymore except in the lab. In clinic, we use its derivatives, which are dicloxacillin, and flucloxacillin. But methicillin's use also led to the emergence of methicillin-resistant Staphylococcus aureus, MRSA, which we'll talk about later. Carbapenicillin was the first penicillin active against Pseudomonas aeruginosa. And Pseudomonas is intrinsically resistant to beta-lactams because it has a chromosomally encoded beta-lactamase. And this is different from the one Staphylococcus aureus use, which is a plasmid encoded beta-lactamase. In the clinic, we use tarcacillin and piperacillin, which, like carbapenicillin, is not susceptible to chromosomally encoded beta-lactamases, and so they work in Pseudomonas aeruginosa. The second big class of beta-lactam is cephalosporins, and they are subdivided into 5 generations now based on the pharmacokinetics and resistance to beta-lactamases. Later generations penetrate tissues better, are more resistant to beta-lactamase, and have stronger activity against gram-negatives than gram-positives. The 5th generation is unique because it also has coverage against MRSA and lots of other things. The third type of beta-lactam is carbapenems, under which we have clavulanic acid, which is actually a weak antimicrobial agent by itself, but it is famous as an inhibitor of plasmid-encoded beta-lactamases. Just note that this is plasmid-encoded beta-lactamase, not chromosomally encoded beta-lactamase. It can be given together with penicillins that are susceptible to plasmid-encoded beta-lactamase, such as amoxicillin and tarcacillin. And a famous combination you would have heard of would be clavulanic acid and amoxicillin combined to produce co-amoxiclav or augmentin. Lastly, we have tazobactam, which, like clavulanic acid, it is famous as an inhibitor of beta-lactamase. Tazobactam and piperacillin combines to give you tazocin or peptides, which is a powerful antibiotic with activity against many gram-positive and gram-negative bacteria, including Pseudomonas aeruginosa. Okay. Moving on to the mechanism of action of beta-lactams. So bear with me, this is some intense theoretical knowledge, but it is important to understand bacterial resistance. So how do they work? Recall the difference between gram-positive and gram-negative cell wall in bacteria. Gram-positive bacteria have a cytoplasmic membrane and a cell wall that consists of a thick peptidoglycan layer. Gram-negative bacteria have a cytoplasmic membrane, also called an inner membrane, and a cell wall that consists of a thin peptidoglycan layer and as well as an outer membrane. Between the inner membrane and the outer membrane is a periplasmic space. All true bacteria have a cell wall, which contains peptidoglycan, which gives the cell wall rigidity. The structure of peptidoglycan is shown on the slide. It consists of a chain of alternating N-acetylglucosamine, or G, as you can see labeled on the diagram, and N-acetylmuramic acid, or M. Bonds between G and M are beta-1,4-glycosidic bonds. Coming off the M is a 4 amino acid peptide chain. As you can see on the right-hand side here, in the case of Staphylococcus aureus, the 4 amino acids are A, ella, D, glu, L, lysine, and D, ella. There's a pentapeptide bridge that links from the 3rd amino acid in the previous 4 amino acid peptide chain above to the 4th amino acid in the 4 amino acid peptide chain below. And in the case of Staphylococcus aureus, this pentapeptide bridge consists of 5 glycines. When synthesizing their cell wall, bacteria synthesizes the peptidoglycan building block, which consists just of G and M and 4 amino acid peptide chain, as well as the pentapeptide bridge. And the synthesis initially occurs inside the cytoplasm. The building blocks then becomes immobilized on the, once complete, the peptidoglycan building block then flops to the external aspect of the cytoplasmic membrane. Penicillin binding proteins then grabs the pentaglycine bridge of the peptidoglycan building block and links it to the sub-terminal D-ella of the growing peptidoglycan chain, displacing the terminal D-ella. So the bond between the two terminal D-ella is where that occurs. So beta-lactam antibiotics have a beta-lactam ring that looks suspiciously like this peptide bond between D-ella and D-ella. And when they are administered, penicillin binding proteins bind to the beta-lactam ring by mistake and become inactivated. And so the bacteria can no longer grow its peptidoglycan chain. Penicillin G led to the development of penicillin G resistant Staphylococcus aureus, which produced plasmid-encoded beta-lactamase that could hydrolyze the beta-lactam ring of penicillin G. In response, we developed methicillin and its derivatives, but then that led to the development of MRSA, which produced an altered penicillin binding protein called PBP2A. So does anyone know what antimicrobial agent we use to treat MRSA? Vancomycin is the answer. Thank you. So vancomycin is a glycopeptide antibiotic. And unlike penicillin G, it is a large charged molecule, which means it is not very lipid soluble, and it can only act on gram-positive bacteria because it can't cross the outer membrane of a gram-negative bacteria. Vancomycin binds to D-ALA at the end of the peptidoglycan building block after it has flipped out onto the external aspect of the cytoplasmic membrane. Therefore, even though MRSA has an altered penicillin binding protein, which is not inactivated by methicillin or its derivatives, it still cannot link peptidoglycan building block to the growing peptidoglycan chain due to vancomycin capping the end of the building block. The fear now is that some enterococci can adapt to use terminal D-Lac rather than terminal D-ALA. If MRSA acquires the appropriate genes from enterococci so that it too can use terminal D-Lac, then vancomycin will no longer work because it can no longer bind to the end of the peptidoglycan building block, resulting in the development of VRSA. Another way that MRSA can develop resistance against vancomycin is by producing extra peptidoglycan, which acts as a sink to soak up the vancomycin, so that there is enough D-ALA for peptidoglycan synthesis to continue, resulting in the development of vancomycin intermediate resistant Staphylococcus aureus, or VISA. There are several agents that can still be used against VRSA and VISA, and you need to do a culture and sensitivity to find the best agent to use. But as we've touched on earlier, the 5th generation cephalosporin is very broad spectrum. It actually works against both. So that's something good to know about. Moving on to aminoglycoside. It is the second class of antibiotics to be discovered after beta-lactams. And there's one particular member of this drug class that everyone should know about. Does anyone know what famous antibiotic belongs in this class? It can be described by some as a dirty drug or a drug with quite bad side effects that some people are reluctant to use. It's actually also on the slide I just noticed. Gentamicin, perfect. So similar to tetracyclines, aminoglycosides bind to the 30S ribosomal subunit. And the effect of aminoglycoside can be divided into 2 stages, and there are 2 sequential stages. Stage 1 is due to the lipid insolubility of aminoglycoside, only a small amount of them can diffuse from the outside into the bacteria. But the ones that make it through binds to the 30S ribosomal subunit, resulting in synthesis of mutated proteins, which make the cell wall weak. As those proteins make up the cell wall. So after the structural integrity of the cell wall is weakened, large amounts of aminoglycosides can flood in from the outside and continue their work. And the end result is that protein synthesis is stopped completely and the bacteria can no longer function. Aminoglycosides work on gram-negative bacteria, but they can also act on gram-positive ones if they are combined with beta-lactam antibiotics. For exams purpose, there are 2 main mechanisms of resistance against aminoglycosides that are highly effective. First being enzymatic modification leading to reduced entry. The second being ribosomal mutation leading to reduced binding. The main side effects of aminoglycosides are nephrotoxicity and ototoxicity, and these must be monitored closely. The second last class is macrolides, and a famous drug in this class is azithromycin. Macrolide binds to the 50S ribosomal subunits, inhibiting formation of peptide bond and thus preventing translation. The main one to remember is azithromycin, as I'm sure everyone have heard of. It has a broad spectrum and excellent tissue penetration. It is primarily used for the treatment of respiratory, enteric, and genital urinary infections. Metronidazole inhibits nucleic acid synthesis by disrupting the DNA of microbial cells, but this function only occurs when they are partially reduced intracellularly by an enzyme called PFOR, which is only expressed in strict anaerobes. And strict anaerobe bacteria include Trichomonas vaginalis and Clostridium difficile, and strict anaerobic protozoa include Giardia and Antimicrobial histolytica. Clostridium difficile infection is associated with the use of a certain medication. Does anyone know what I'm referring to? It's actually a bit ironic that it is caused by the use of, okay, someone said clindamycin, but it's really, evidence shows that Clostridium difficile infections can occur after a single dose of essentially any antibiotic. And so it is really important to remember its treatment. What do we use for Clostridium difficile infection that is not metronidazole? Oh, fecal transplant is a good one. That's, I think I haven't seen one used clinically, but I know that the research is very promising. But the other antibiotics I was thinking of is vancomycin. So you will you will determine the severity of the Clostridium difficile infection first. And for first episode, mild or moderate infection, you can use either metronidazole or vancomycin. For severe infection, you use vancomycin. And for complicated cases, you use both metronidazole and vancomycin. That is just a general guide, but please follow your hospital's specific guidelines for this. Now we've reached the end of this lecture. I just want to finish with a few recap if you still remember. Let's see. First question, what is the mechanism of action of tetracycline? What does it bind to? It binds to the 30S ribosomal subunits. Amazing. I'm so impressed that you guys remember that well. The second question is, what does beta-lactam antibiotics do? There's a protein that they act on, kind of named after them. They bind to penicillin binding proteins to prevent the peptidoglycan building block from growing. That is perfect. Thank you for the answer in the chat. Third question. Well, that's an easy one. So Staphylococcus aureus develop plasmid encoded beta-lactamates. And what do we use to treat them? Not vancomycin. That's actually one step up. Vancomycin is used for sorry, what did I say? Yes, no, vancomycin is used to treat MRSA, but normal penicillin G resistant Staphylococcus aureus is treated with methicillin or its derivatives. The one you would have heard of is flucloxacillin. Great. For MRSA, what does it do? Does anyone remember, or I can re-explain that again? So a MRSA produces an altered penicillin binding protein called PBP2A, and we treat MRSA using vancomycin. And vancomycin works by binding to the DLR at the end of the peptidoglycan building block to prevent further addition of penicillin binding protein. Question 6, what does VRSA do to confer resistance against antibiotics? It's also to do with the terminal section. So it uses terminal DLAC rather than DLA so that vancomycin can't bind to it, because vancomycin binds to the DLA, the bond between DLA and DLA. So so that's what VISA do. They use terminal DLAC rather than terminal DLA, and VISA just produce lots of peptidoglycan so that they consume all the vancomycin. Question 7, gentamicin, which is an aminoglycoside, acts in via 2 stages. The first being the aminoglycosides, small amounts of them bind to the 30S ribosomal subunit, resulting in synthesis of mutated proteins. These mutated proteins then result in a weak cell wall for more aminoglycosides to flood in. What are the 2 major side effects of gentamicin we look out for? Ototoxicity and nephrotoxicity. Great. And question 8, what is the mechanism of action of azithromycin, which is a macrolide? It binds to 50S ribosomal subunit and preventing translation. And last question, what are some agents we use to treat Clostridium difficile infections? Metronidazole and plus or minus vancomycin, depending on the severity. Amazing. So that's the end of what I've prepared today. I want to thank you all so much for concentrating and contributing. Apologies for a few errors I've made along the way. Hopefully I've corrected all of them. It's been a long day for me, unfortunately. But I've really enjoyed having these discussions with you guys. And hopefully I managed to teach you some important concepts that you can use in clinical practice. Thank you very much, everyone. If there are no more questions, I would like to send you off to enjoy your evening. Thank you very much.